Well, greetings everyone. Welcome to another educational event in the AMA Steps Forward webinar series. Before we begin, we want to quickly review some housekeeping items. This session will be recorded and will be available after the event. If you have questions, please place them in the Q&A. We will have time at the end of this webinar to answer many, if not all, of the questions. But we also encourage you to reach out to us via the Steps Forward inbox, which is steps forward, one string, at ama-assn.org for all questions that we're not able to address. So we're delighted that today's speaker is Dr. Paul DeChant, who's an organizational well-being consultant and was previously the CEO of the Sutter Gould Medical Foundation. Now today, Dr. DeChant will be presenting Crossing the Divide, Building Bridges Between Practicing Physicians and Administrators. Welcome, Paul. It's a pleasure to have you join us today. So I'm going to pass our virtual microphone over to you.
Well, thank you so much. And I'm really honored to have this opportunity to speak to so many members of the AMA about this as one of many aspects that help address this challenge we've got with burnout. I'm so impressed with the work the AMA has done. I actually have known a number of members of the AMA for quite a while now, and have really been a great supporter of the Steps Forward program. So it was my pleasure to be able to participate in it as well. This particular component that I'm going to talk about is something that hasn't been discussed perhaps as much as others, but it's still a major underlying issue of the lack of trust between senior leaders in organizations and frontline clinicians. So we'll be diving into that, talking about how to address that. What I'd like to start with, well, first of all, just to introduce myself very briefly. I'm a family physician. I practiced for 25 years. During that time, and for some time afterwards, I had progressive roles in management in healthcare organizations around the country, both large and small practices. And ultimately, I became CEO of a 300 physician group in the Central Valley of California, the Sutter Gould Medical Foundation. And there I saw the opportunity to actually make the changes that I've been working towards my whole career. We built a transformation of the organization on a theme of returning joy to patient care. And in that process, did a lot to truly honor the great knowledge work that our clinicians on the front lines were doing. Putting that all together, over the course of 5 years, we were surprised. We actually got recognized by the California Healthcare Performance Information System and Consumer Reports as the top performer out of 170 groups in the state of California 2 years in a row. We didn't even know they were doing that process. And we moved the physician satisfaction from the 45th to the 87th percentile on the AMGA's provider satisfaction survey. So we knew something was working, and in fact, in that process, we were able to improve performance across all the metrics of the organization. As most importantly, well, not most importantly, but certainly importantly, including our financial performance, because we cannot do this work in a way that is not financially sustainable. So that proof of concept said this could be done. We learned a lot of lessons from that. And then I've spent the last 7 years actually doing consulting with health system leaders around the country about how they can do similar things to improve their workplace and therefore reduce burnout. And in particular, Dr. Krasinski, who's heading up so much of this effort for the AMA, has been a real inspiration to me in the work that she's done around all of this. So that's kind of my background, but let's go ahead and get started. Today, what we'll talk about first is our learning objectives. The goal today is to recognize that there are these current drivers of distrust between physicians and senior leaders. And there are methods that we can use to strengthen that trust, including transparency between these two factions of our organizations. And then we'll outline those strategies that can truly improve the relationships and change the dynamic significantly. How will this help you? Well, hopefully you'll have a far better understanding of the drivers of physician to administrator distrust and provide you with some simple and practical ways that you as a practicing physician, or if you are in an administrator role, can develop a deeper understanding of each other's challenges, and then take actions that actually benefit both of you. And in this process, to make sure you've got some clear, concrete things to work with, we'll talk about examples from organizations that have done this effectively. All of this information as well is on the Steps Forward website under the module that's dedicated to this. So anything you don't pick up here today, please feel free to go there. And there's a lot of other handouts or additional information that's available there. So I really encourage you to look there if you have any questions at all. You know, the challenge today in many organizations, not all, because there are certainly some organizations that have great leadership and have learned how to really connect to their frontline clinicians. Unfortunately, there are so many that don't yet at this point. And there's these challenges, these relationship challenges develop in some ways because we both, administrators and physicians, justifiably think of ourselves as highly trained and skilled knowledge workers. And so we come with that expectation that that's the way we'll be perceived and treated by each other. But these relationships are strained often and really now at all-time lows in many organizations. The challenges come in part because as physicians, we'll think of administrators as though they really don't understand, or perhaps worse, they don't care about the challenges involved in caring for patients. And we feel as though we're being treated as production line workers instead of being honored for the incredible knowledge workers that we are. And we feel as though administrators are not allowing us control over some of the most basic things about the way that we take care of patients, about our schedules, our support staff, even clinical decision-making. Now, that's from the physicians and how we as physicians perceive administrators. On the flip side, administrators perceive physicians as thinking, you know, those doctors really don't understand the challenges of running complex organizations. And they don't really care about the financial challenges that are required to ensure that the organization can be sustainable. And it's worth taking a little time to unpack some of this here, because these are significant issues. You know, Peter Drucker is a well-known management consultant. He's since passed away, but was a true leader in the field. And he had two things to say that were really important in this. The first is that healthcare is it is the most complex and challenging type of organization to run, more so than any other industry. And so when we look at senior leaders and see what they're trying to do, they're feeling that strain. We as physicians oftentimes don't see that, don't realize, because we've lived our lives in these types of organizations, we don't realize how much harder it is to run a healthcare system than it is to run a manufacturing company or a financial services company. That said, the other thing that Peter Drucker said is the definition of a knowledge worker, which is someone who knows far more about the work they're doing than the people who are managing them. And so a manager is trying to manage a knowledge worker, actually doesn't know what the worker's true work is, what the worker's true challenges are. It's not the same as someone who's on a production line or managing people that are, you know, making hamburgers, where the manager actually knows more than the person doing the work and can easily instruct that person. Not so with healthcare. We as physicians have knowledge that is important to value. And yet sometimes we get this disconnect where as administrators are under this strain to make sure that their organization is financially viable. They'll come to us and set expectations for productivity that may not take into account the challenges of what's being expected. Meanwhile, we as physicians are setting expectations of the support that we need, which administrators may view as too expensive in order to maintain the bottom line. There's so much opportunity to break through this dynamic where we don't understand each other. And so that's what we'll spend some more time talking about today. We cannot be treated, as physicians, we cannot be treated like production line workers. It just doesn't work. And it's one of those things, as we'll see, that really drives burnout. But as physicians, if we're truly responsible professionals, we also have to find a way to make this work within a financially sustainable model. Because if we don't have a margin, we can't live our mission of caring for patients. So before we, to get background on this, I'd like to talk a lot about burnout and what the drivers are and why this applies to this particular topic. To start, I like to talk about what I perceive as the opposite of burnout, which is professional fulfillment. That's a commonly shared definition from Dr. DeChant, the work that he's done with well-being, and now particularly leading the Chief Wellness Officer programs around the country, where he's Chief Wellness Officer at Stanford. He's worked actually very closely with members of the AMA on this as well. But when I think about professional fulfillment, I think about how, as a physician, we are able to spend our time in what's most meaningful to us. And for many of us, that is being deeply connected to our patients, so we're making a difference in our patients' lives, or doing a procedure that's truly life-saving and makes a difference in our patients' lives that way. Others of us really find true professional fulfillment in teaching and bringing up the next generation of clinicians. And in addition, others find true value in doing research, discovering the new knowledge that helps all of us to deliver better care. All of these areas are where we find professional fulfillment. One of the challenges is that we spend so little time actually deeply focused on what provides professional fulfillment, because we're so required to spend time on other things. In fact, some of the work that's been done by people from the AMA have shown we spend about 1/3 of our time in these areas where we're deeply engaged, and about 2/3 of our time doing data entry, dealing with other administrivia. And when you think about that, the highly trained, great skills that we have are being wasted because we're doing things that someone else could do. If we could just flip this ratio, so we spend 2/3 of our time focused deeply on being connected to what's meaningful to us, and 1/3 of our time on those things we have to do in order to do the work we love to do, it would be life-changing and actually transformational for the entire healthcare system. The thing is that what we find instead is that we are driven to burnout. And burnout, as I think of it, as the opposite of professional fulfillment. I've had the great pleasure of working also with Dr. Christina Maslach, who created the Maslach Burnout Inventory. And the work that she did with her colleague, Michael Leiter, they identified 6 key drivers of burnout. The first one is work overload. We work in chaotic, time-pressured environments that are not only challenging there, but we're seeing increasing information overload even before the pandemic hit. Medical knowledge doubled every 73 days. When we are overloaded, we start to experience the second driver of burnout, which is loss of control. Control is a big deal to us. That's why we give up the decade of our 20s in order to get the knowledge and skills we need so we can take control when we need to. In fact, it's something we expect as one of those intangible rewards of committing ourselves to this profession. There's other rewards we look for as well. We look for professional recognition. And in fact, insufficient reward is the third driver of burnout. One other reward that we look for that we're finding harder and harder to get these days is that collegiality with our colleagues, certainly with other physicians, with APPs, with nurses, that ability to connect with the community. There's so many wonderful people that work in healthcare. And in fact, breakdown of community is the 4th driver that Maslach and Leiter identified as of burnout. And we see that so much these days. You know, we're in the quotes, old days when I trained back in the Pleistocene era, you know, primary care doctors spent a lot of time in the hospital. Everybody connected in the doctor's lounge. We'd stand around the nursing station, talk to each other about patient care. It's so much more rare to see that these days. I've even heard of hospitals being built without a communal room for the doctors to come together. We do see doctors together in a room, but quite often they're sitting interacting directly with the computer and the EHR, not interacting with each other. And people are too busy to get together at lunch or in the evenings anymore. So we're seeing that real decimation of the community with our colleagues. When we get separated from our colleagues and our lives are challenging like this, we start to wonder if we're being treated fairly. And in fact, absence of fairness is the fifth driver of burnout. We see this as changes come where we're told, here's a new administrative regulation you have to follow. It makes no sense. It feels unfair. There's also growing challenges around fairness with the changing demographics of the physician workforce. I am an older white male. I have never had to really experience an unreasonable challenge to my professional credibility, like so many of our workforce now. I don't have to deal with being questioned as to whether I'm a nurse or a doctor. I don't have patients refuse to see me or question my credibility because of my nation of origin or the color of my skin. But the growing percentage of our workforce is, and they're incredible, everyone is incredibly valuable and everyone deserves to be treated with respect and fairness. And this is an area we still have a lot of work to do in. Lastly, it's the question of when all of this is going on, we start to wonder if what we value is truly aligned with what our organization values. Conflicting values is the sixth driver of burnout. Now, why do I go through all this? It's because a lot of this has to do with the actual manifestations we see of burnout, and then ultimately how the relationships impact each other. So here are those drivers we just talked about. What Maslach and Leiter found was that there's a direct correlation between the drivers and the manifestations of burnout. We all know the manifestations, right? Particularly emotional exhaustion and cynicism or depersonalization. What they discovered was that actually, and not surprisingly, work overload drives exhaustion. And so many people really think that's what burnout's all about is, if we could solve that, everything would be fine. In fact, those other 5 drivers of burnout drive cynicism. And if we're going to make a difference and improve our professional lives and improve the experience for our patients, we have to address both of these. As we address emotional exhaustion, we actually create the space for discretionary effort for us to work to improve the care we're providing, to improve the way we deliver that care, to improve the quality and safety. And as we address the drivers of cynicism, we actually open the door for greatly improved engagement. I don't know where you work, if you've been through an engagement survey in your hospital or health system lately. Many people are pursuing this deeply. Many of those engagement surveys cover some, but not all of these drivers of burnout. And when we think about the opportunities we have to feel truly engaged, to get engaged, because we actually have control, we experience acknowledgement and a reward. We're working together as a community, being treated fairly and aligned with our organization. Engagement can make tremendous opportunities to then help us redesign workflows so that we reduce that work overload. It all really ties in together. The other interesting and perhaps a bit more theoretical, but worth just considering here, is the connection between Maslow's hierarchy of needs and Maslach's drivers of burnout. Now, Maslow's hierarchy of needs, if you remember back to Psych or Sociology 101 in college, you probably learned about this, the 5 levels that people go through in order to reach self-actualization. When we stop and think about it, being burned out it actually takes us to the opposite end of self-actualization. And when we can get to self-actualization, it's actually what we've already talked about is professional fulfillment. So let's take a look here and see these impacts. First of all, work overload. When we're working so much that we don't have time to eat, or we don't even have time to use the restroom, well, that's impacting our physiologic needs. And so that makes it very difficult to move up the hierarchy of needs if we're not even able to take care of the most basic physiologic needs we have. When we're not in control, there is significant challenge of safety. All the work that we do on safety these days in delivering patient care, safety for both the clinician workforce and for the patients, depends on us being able to control our environment, being sure that everything is in place and working well. Moving from there, we see as the community breaks down, this whole concept of love and belonging, of actually being considered part of a community, is at risk as well. So that breakdown of community driver has a direct impact. Insufficient reward drives esteem. If we're not being acknowledged and appreciated, how can we feel that esteem for ourselves or that sense of esteem from others? And in healthcare, we're actually pretty harsh about this. It's not the kind of thing we focus on as much as, frankly, a number of manufacturing firms I've seen do more to honor the people working in those firms than we do. We're deeply mission committed to caring well for our patients, but quite often in determining that and ensuring that we have this mindset, we want to make sure patients get the best possible care. We have to make sure the caregivers are the most knowledgeable possible. An old school way of thinking about this was we really had to almost intimidate students and residents as they're learning in order to make sure they learn everything they need to know, as though that really drove that sense. And in that case, we often got beaten down. I certainly remember on rounds, essentially being pretty paranoid about whether I was actually being adequate or not in the care I was delivering to patients. Ultimately, to achieve self-actualization, to achieve that professional fulfillment, we need to know that we're being treated fairly and be aligned with the values of our organization. When we put all that together, again, this truly changes the underpinning dynamics of what's driving burnout or what creates the opportunity for professional fulfillment. So how does all that have anything to do with this issue about this chasm and divide between frontline physicians and senior leaders? Well, when we look at these drivers, and particularly these four, lack of control, breakdown community, fairness, and values, there's a lot that's happening in the relationships that are key. So let's talk about some steps we can take in order to actually create better alignment between practicing physicians and senior leaders. These will include, and we'll go through them in more detail, assessing the status of these relationships, opening up communication channels, educating physicians and administrators on each other's roles, so we create that understanding and empathy for each other. And then from that, building trust. Because without trust, we really can't have the kind of relationships we need in order to work together effectively. So let's look at that first one, assessing the status of the relationship. There's times when we'll see events that let us know, they're almost sort of trigger warnings. There might be a problem here. And many of these you might be familiar with this, concern about increase in physician turnover, increased burnout rates on surveys, decreasing ratings on the engagement surveys, or we're seeing an exodus or threatened exodus of specialty groups. And in fact, it's not just subspecialty groups, primary care specialty groups we've seen leave large health systems because of the way that they feel they can actually manage themselves better. And we see this pendulum continue to swing between physicians being independent of hospitals and health systems, getting overwhelmed by the challenges of dealing with insurance and other issues that are going on, deciding there's comfort and protection in being part of a system, getting into the system, and then finding, this system isn't really working that well for me. Maybe I'll actually be better off out of it and moving back out again. So these are moving back and forth. There's certainly been the huge shift has been from being independent to being in an organization. But that's not, but it's not universal, and we are starting to see changes there. There are increasing challenges in physicians supporting new strategic initiatives. When a hospital or health system decides, we need to put up a new hospital in this part of town, start up a service line for cardiovascular care or oncology or orthopedics. It doesn't, or some new innovation or bringing in telemedicine. Things like this don't always, if we're not involved as physicians in making these decisions, we end up seeing that physicians will challenge these decisions. And we're actually seeing no confidence votes of administrators by physicians. This has happened multiple times, and especially lately, as more and more mergers are getting announced between health systems, it used to be a hospital would get acquired by a hospital or a small health system. Now we're starting to see mergers and acquisitions where one moderate-sized health system is being acquired by a larger health system. And then just as those get announced, people think, okay, this is the way it's going to be. There's stirrings that start up in one or the other organizations coming from the physicians. And ultimately those challenges lead to these mergers being stopped. And they happen almost monthly now. I'm seeing this. And in that process, actually, quite often there's a no confidence vote for the administration of that hospital. And we've seen senior leadership actually turn over because of those physician no confidence votes. So there's many ways in which we realize it's time to take a good look at these relationships. These are the big manifestations that there's a problem. How do we assess them? Well, there's a couple of great tools that are available. One is the AMA's organizational biopsy. It really looks at multiple domains of the culture, practice efficiency, including leadership quality. And it'll give you a sense of how well the organization's working and how much strain there might be in the relationship between leadership and the physicians. The Mayo Clinic Leadership Index is also a great way to measure the quality of leadership, because that senior leadership quality is so important to the function of the organization as well as to the experience of the physician. They've demonstrated that improvements in physician leadership in that Mayo Clinic Leadership Index score has a direct correlation to reduction in burnout for the physicians reporting up to that leader. Now, certainly organizations that do engagement surveys, you can see, and these engagement surveys are normed with other systems around the country, and you get a percentile ranking. When your rankings are not where you want them to be, and particularly it's not uncommon to see organizations where rankings are at the 25th percentile, even lower 10th percentile. Those are warning signs, pretty much glaring at you. There's an issue here that needs to be addressed. Once you know there's an issue that needs to be addressed, then the big question becomes, well, what do you do? And certainly opening up the communication channels are key, just to start to learn and understand from each other what people see as the issues. And so a great place to start, particularly if you're a senior leader, is to start a CEO of Practicing Physicians Forum. There's a number of ways to structure these. They can be held monthly, they can be held quarterly. They can include anywhere from a few physicians, 5 to 7, up to 20 or more, depending on the size of your organization. There's questions about how do you choose who should be on that forum. If the only people that end up on the forum are people that are already in formal leadership positions in the organization, then it's probably not going to achieve the communication that you're really looking for. And as there are many informal leaders in our organizations who have great insights, you certainly want to bring in people who are there to be constructive. As I've found as a CEO, if someone was simply always a naysayer, essentially almost felt like they were a saboteur to our ability to deliver care, I really didn't want to have that person in that council, but I did want people who could ask honest questions that were challenging, but were done in a way where we were collectively looking towards solutions, not simply refusing to address, refusing to accept anything as a possibility of improvement. So these physicians can be elected by physicians in the organization overall. They can be chosen as representatives from different departments or locations. There's any number of ways to do it, but you want to build a constructive but respectfully challenging group of physicians that are working with the CEO, and then get a chance to sit down once a month, once a quarter, oftentimes in a more relaxing situation over dinner, something like that, to really foster the communication, building an agenda for that, not a very deeply detailed formal agenda, but having some basic things, updates from the CEO about what's happening in the system, and perhaps interesting things about what's happening in the community that's impacting the system, but a lot of time, the vast majority of the time, should be open communication for the physicians to share their concerns with the CEO. Other ways to get that communication and open those channels up are town halls. Now, in town halls, those are open to everyone, and in fact, everyone should be encouraged to attend. As we've gone through COVID, things have been more remote. Certainly, we've learned to do these type of meetings remotely, and they can continue that way. We're starting to see a move from where everything used to be in person. Through the pandemic, everything's been virtual. Now we're moving into essentially a hybrid situation where meetings will be both. There'll be people in the room and there'll be people connected to the meeting, but not in the room. And those can work very well with town halls. Again, a presentation by the senior leader, and then open opportunity for discussion. Sometimes that's a little more challenging to manage a particularly frustrated physician in their discussion. That's all right. There are ways to deal with that and to move any challenging discussion, to give it enough time to air, but then to build a follow-up visit with that person to address their particular concerns. Online idea generators, actually there's a number of those available. Some of them are through the Steps Forward website. If you go through this module, you'll find a link to another module that actually addresses that. And there are some other opportunities like that as well. There's one called Wiki Wisdom that has worked well in some healthcare organizations and truly made a difference to help senior leaders hear from people on the front lines about what their concerns are. People who otherwise might never have had that opportunity to get that idea in front of a senior leader. And then just having social events to break down the formality barriers and actually just help people talk about things besides strictly work issues, get to know each other a little bit. There's nothing like getting to know someone a bit more to make a difference in how you're relating and building trust. Next, educating administrators and physicians about each other's roles. We really don't know. To educate administrators, I highly encourage. In fact, when I give a talk on burnout and someone asks me at the end of it, what's the one thing that we should do differently next week? I will say, if you're an administrator, go shadow a clinician. Actually follow them for a few hours through their day to see the reality of their experience. It's too easy as an administrator to sit with a committee in a conference room looking at spreadsheets and reports and making decisions about what changes need to happen in the organization. But when we're doing that, we often miss the unintended consequences and implications of those decisions that impact direct patient care. So there's nothing more valuable than shadowing clinicians to understand what that's like. And then as an administrator, attend huddles, not to come with solutions, but to learn how well people on the front lines are able to solve their problems. And when they're not, being able to bring resources to help them address that problem solving better. These two approaches are more than simply that old concept of management by walking around. I don't know about you, but when I was a practicing doc, if I'm out busy and I'm usually half hour behind, at least in my schedule, I'm trying to keep up and I see the administrator walking down the hall towards me, the last thing I wanted him to do or her to do was to ask me, how's your day going? Because I had two choices. I could either tell the truth and get caught up in a half hour to 45-minute discussion and get further behind, or I could simply say what got me through that as fast as possible and let me get on to caring for my patients. Oh, it's going okay, thanks. In either way, that's not really getting to the issues, or it's creating more of a problem. By shadowing or by attending huddles, administrators can learn a tremendous amount. Now, one of the keys for this is that we as physicians should invite administrators to shadow us and do it in a way that's open and supportive and really creates that opportunity. Not every administrator is aware of how well this can work, but if you are, and you see any opening from your person that you report up to, or multiple levels above you that might show some interest, take a chance, invite them, just welcome them in and thank them for being there. To educate physicians about administrators, we need, as physicians, leadership training. Now, we've gotten bits of it here and there, and as people move into roles, there's more of it available, and there are many organizations now developing physician leadership academies and similar things. All of this is important because caring for a patient and being able to diagnose the patient's problem and solve that patient's problem is completely different from taking care of an organization, being able to understand and diagnose the problems of the organization and treat those problems. So whether you get leadership, there's many avenues by which to get leadership training. There's certifications available through the American Association for Physician Leadership, the American College of Healthcare Executives. There are master's programs that are available either online or in person. There's a lot of great opportunity for executive coaching and mentoring. And when you realize that as physicians, particularly when you're in a new role as a leader, we think we can do this. We're always expected to be perfect and able to do whatever's thrown at us. This is hard work. And when you get thrown into a completely new role as a leader, you need a coach. And in fact, you think about high-performing athletes, all of them have coaches that are working with them individually or with their team all the time in order to be performing at a high level. Somehow, that's escaped many of us. We don't realize how much value there is in having that person that you can turn to, you can bounce your ideas off of, you can discuss your challenges with. And coaching is invaluable. And then focused leadership development programs. Many universities around the country actually have these. They're not a full MBA. They're a focused education on a certain aspect of care. Absolutely important. And then gradually gaining management role experience by starting out as perhaps chairing a committee or being a director of one location. And then as you learn more, moving up into other roles in an organization. That's so important and valuable. You can do this, and you should do it if you're truly interested in making a change. When I started in med school, going through residency, I never thought I'd be leading anything. I thought I was just going to take care of patients. But I got into leadership because I couldn't keep my mouth shut when things didn't go well in my office. And so people said, "Oh, you got a problem, Paul? Well, okay, why don't you join this committee? You can help solve that problem." And then ultimately I would chair a committee, became a medical director, moved up, became a president of a division, ultimately became a CEO. It was a progressive process that started because I was frustrated. I wanted to make things better. I do find sometimes when I'm working and mentoring with other aspiring leaders, some tell me they want to be in these leadership roles and become a CEO for other reasons. They want the power, recognition, and prestige. They're burned out of caring for patients. They want an escape from burnout. Those are not good reasons to go into leadership roles. And you'll probably find that you're just as frustrated in the leadership role as you were in your clinical role if that's why you're doing this. But when you are pursuing it for the right reasons, these training programs are just invaluable. And then there's the opportunity, as we've begun to understand each other and we've opened communication, to truly build trust. Here, structuring the leadership teams in the organization around dyads or triads makes a world of difference. So at whatever level, if you're in a medical group, tends to be a dyad, an administrator, and a physician who are leading at a site, within a department, within a division, or the organization overall. In a hospital, it's often a triad because it's not only just the doctor and the administrator, but the nurse who's also leading that particular unit is involved. And as we work together, we can actually do the leadership training programs together and collectively learn. The dyads and triads allow the clinicians who are in those triads or dyads to spend more time clinically while they're still deeply engaged in the appropriate decision-making and guiding and making sure that decisions are getting implemented well. Another opportunity, collaborative strategic planning. Actually having the leadership bring physicians into the strategic planning discussions. We are incredible knowledge workers. When an organization is deciding about a strategy to have an impact, we bring two things as physicians to that discussion. First of all, industry knowledge about truly what's happening and what's cutting edge in the industry. And secondly, deep community knowledge, because we're caring for patients, we're hearing what their needs are in the community. Those two factors are so important in strategic planning. And when we're involved in the strategic planning and the decisions made, even if it's not exactly what we were hoping for, because we've had input, we're far more likely to be actively supportive of those decisions and make sure that whatever that decision is, that whatever that plan is, it gets put into place. A third, and probably not as well known way to build trust, is an organizational compact. And a compact actually comes from the things that we as physicians often aren't too excited about. Things like mission statements and vision statements and value statements. You know, we think of those, they're plaques that are on a wall somewhere, and we figure, you know, we all have the same vision, which is to, you know, to have a healthcare organization that's providing great care, and a mission to care for each patient as well as possible, and values of quality and safety and, you know, access and recognition of clinicians. Those, you know, we just take those for granted. But what we're finding quite often, when organizations merge and we think we have the same values, we think we have the same mission and vision, in fact, often those mergers break down because as those two organizations get to know each other better, they realize, wow, we really do have a different culture here than the other organization. The way to address those challenges is one way, is through these organizational compacts. And a compact is an unwritten agreement between two parties, in this case, between the leadership of the organization and the physicians. And it's a way to look at and understand the values and how those values will be honored. If we have a value for quality, perhaps one of the ways that it's not uncommon to see an organization say, we value quality, therefore we expect our physicians will close care gaps at every visit, for example. And that can sound like very noble, great idea, until you're the physician trying to close the care gap at the visit and you're finding, you know, I don't even have the information on when the last mammogram was, or what's up to date with the latest changes in terms of immunization requirements. So a compact is reciprocal in that it not only would state that value or that way to exemplify the value of closing care gaps, but it also states that the organization will reciprocally ensure that the physician has what they need in order to honor that value effectively. They'll make sure that the way that the information comes through the EHR or a registry, that it's front and center for you. You know what to do. It's easy for you to do it. You probably may even be working with your team, so your support staff have actually teed these up for you, and all you need to do is approve them. That way you're working together as an organization to achieve those values as the organization collectively agrees to them. So there's just so much opportunity there when we go through that process. Now that compact gets developed, it's not something that gets done on a 1 or 2 day retreat by some senior leaders and it just gets sent out and plugged up on the wall again. It gets drafted initially and probably in a 1 or 2 day session, but then it gets shared as far out into the frontline caregivers of the organization as possible. And discussions happen at staff meetings. And those discussions bring information back to further inform the compact. So over the course of 6 months or a year, it gets really pulled together, finalized, and everyone agrees to it, and at least has had input on it. So those are key things. Those 4 steps are really key. Some pearls to come out of this. Building bridges can actually reduce burnout and improve well-being. The more we can be connected, and there are, as we've discussed, there's challenges here, but they can address some of the key drivers of burnout to a degree where it makes a world of difference. And as that trust grows, then our organizations truly can function more effectively. We can adapt more quickly to change, and we can be better able to deliver on the mission of providing great patient care, but also ensuring that our caregivers are cared for as well. In fact, when we do this work well, we end up with empowered physicians who are aligned with the organization that can quickly adapt to any changes happening in our environment. And we've seen this through the pandemic. Those organizations where those relationships were solid to start with are the ones that actually did best through the pandemic, had the least stresses, and were able to manage through incredible challenge, which isn't kind of too surprising. Isn't that what Darwin said in the first place? That just like an organism is most likely to survive, not because of its size, its strength, or its market share, but because of its ability to adapt to change. It's the same thing for our organizations. While we can, some organizations just try to get big or powerful or some other approach, the key to an organization that's going to thrive through all the changes that are still to come in healthcare is when we can rapidly adapt to the external environment. And we do that by having trusting relationships between our leaders and frontline physicians. So with that, I would just implore you to think carefully. What's your role in reducing burnout and making a difference here? Because it's going to come down to you. Are you ready to make changes in how you relate to administrators, or if you're an administrator, in how you relate to physicians to truly drive this work forward? So I thank you for this. I'm going to turn it back over now for a couple of updates on what's happening with the AMA.
Thank you, Paul, and outstanding presentation, a lot to digest, and wanted to remind the viewers that there are some resources that are available through the AMA's website, ama-assn.org, not only to deal with the Steps Forward program as Paul has outlined, but also things related to the COVID-19 resources, caring for caregivers during COVID-19, as well as telehealth implementation playbook and the behavioral health integration in physician practices. Next slide. We also want to remind everyone that we do have ongoing webinars. The next one is scheduled for June 24th, Healthcare Technology and the Human Connection by Dr. Adrienne Bossi. We hope you'll sign up for it. Next slide. And then finally, if you have any questions or feedback, please reach out to us at stepsforward@ama-assn.org. So we will now switch to our Q&A. We will ask again, if people have any questions, to put them in the Q&A or the chat box. I'll monitor that. But we do have a couple of questions, Dr. DeChant, to start off with. And the first one is related to the issue of, you've kind of highlighted the individuals being involved, being an administrator or being a physician. Does that suggest that you really need to have great leaders of people, or can you create a system of interactions that are going to be forcing people literally to make the right choice when they're talking about interaction, working together, things like that? So again, your thoughts on, do you have to have this be so people oriented to have the right people, or can you create a system that regardless of who you plug in, they're going to be kind of channeled into making the right decisions?
Wow, I love that question. It's so important because it really is very similar to how we think about great patient care. So much of the burden back in the old days was you had to be a great doctor to make sure great patient care happened. That's what drove safety and quality and all that. We now know it's the systems in which the care is delivered that has so much impact. It's not so much the people as the system that makes the difference. It's very much the same with leadership. You can have a great leader and have an organization that's really got a dysfunctional design, and it can be pretty impossible for that person to succeed. And you can have people who don't necessarily start with those great leadership qualities, but being put into an organizational approach and system that fosters that, indeed, you can make a huge difference. So it's certainly a combination. Just as in providing great care, we need to have that body of knowledge, that skill set, in order to provide care well. But we need the system in which to do it. Absolutely the same with this issue. We really think about leadership as caring for the caregivers, and we need a system as well as good people who know how to care for caregivers in order for that to work properly.
One of your earlier slides, when you were comparing the physician versus the administrator, and you highlighted that the physician doesn't understand the economics, if you will, spreadsheets, and Clearly, one of the degrees to try and get that knowledge is an MBA, a Master's in Business Administration. Do you find that if a MD, MBA is really a better degree to get than some of these other post degrees, if one is interested in communicating with administrators, especially on finances?
It really depends on every one of these training programs varies. Some of them, even the MBA programs, some are strictly have physicians in the classes, others have a mix of physicians and hospital leaders. And there are certainly through AAPL or ACHE courses specifically on things like finance that are important, certainly, that are far more important to the knowledge base of an administrator than to the knowledge base of a physician, where you can get that kind of knowledge. Overall, generally an MBA would probably be a better overall approach, but it's going to vary by institution, by faculty, and by the effort that you put into it. So some of that guidance would be, depending on where you're at in your career, if you're early in your career and you're really interested in this, an MBA can be a great way to go. If you're later in your career, you think, man, I don't want to spend that much money and commit that much time when I've got 5 to 10 years left to practice and perhaps be in these roles. But I've got a tremendous amount of experience already. I can build on that with some focused learning. That can be a good way to go also. There are certainly great leaders who have only an MD after their name. They have not pursued an additional degree, and they do a fantastic job. And there's people with the MD, MBA who really, frankly, aren't great leaders, because they haven't been able to incorporate a lot of these core concepts into the way that they work. So, from a longer term standpoint, getting both, the one other thing is it certainly reduces any question of your credential. Right. If you show up with the MD, MBA behind your name, people at least have some baseline assessment or some sense that, you've got a body of knowledge that you can bring to the table.
And I think that's why that's important, is that many medical schools in the last 20 years have started developing combined MD, MBA programs. So if I'm an administrator and I'm trying to find somebody that maybe can understand, taking someone who's an MD, MBA, but has never been in clinical practice, their ability to understand some of the nuances may be less. And so, again, for the viewers that are administrators that are looking to try and put things together, it's not only the degree, but what's the clinical background that one can develop.
Oh, absolutely. Absolutely. I couldn't agree more. I really appreciate you bringing that point up. People who go through straight from get the MD, MBA together even before perhaps they've gone through residency, or even come out of residency and immediately get an MBA. If you're going to go into a startup, or you're going to try to run a pharmaceutical company or something like that, fine. But to truly run a healthcare provider organization, spending time in the trenches first is just so important. So you really understand everything involved far more clearly.
One of the challenges that many organizations have who identify the need to have that physician leader is the struggle. Do I homegrown it? Do I take a seasoned clinician that's well respected amongst their peers and try and get them moving up? Or do I bring in somebody from the outside of the organization? So in your recommendations for an organization that's going to bring in somebody from the outside to fill a role, chief medical officer, chief strategy officer, chief information officer, or some other role, how would you recommend that they orient themselves to the clinical staff so that they can be a trusted physician and not someone that's just considered, oh, well, you've got an MD, but you're just a suit?
Yeah. I think it's important to be trusted both by the MDs and by the other administrators when you come in from outside. To be trusted by the MDs, certainly, spending time, probably, depending on the size of the organization, probably 3 months, really learning, going around talking certainly to all the department leaders, but also shadowing. We talked before about shadowing clinicians to see the work they're doing, You
Right.
build such great relationships when people know you care enough to spend time with them like that. Going to town halls, being, really open, just finding every opportunity to talk to people is important. Equally important, if you come in as the CMO, new to an organization, the rest of the C-suite team won't necessarily trust you to
Right.
be on their side, quotes on their side. They may be thinking, well, you're a doctor, you're going to be more of a doctor than you are an executive. In fact, I know personally, I was accused of that in one place where I was, where there was distrust between physicians and the senior leadership. And I was in the middle of that. And I was told, well, you're way too much of a doctor instead of being a leader. Uh, and personally, I was working that balance of understanding
Right.
the incredible knowledge work of physicians and what people needed to understand this better.
Right. And then final question. So the issue of getting practicing physicians engaged with the CEO in a forum after hours, many practicing physicians, they kind of say, hey, wait a minute, the CEO is getting paid for that, or the administrator is getting paid for that, and I'm having to put up my time. So in your experience, do you find that compensation to the practicing physician for participation on committees and other sort of things where there's a hybrid of administrators and practicing physicians, that compensating them for their time is reasonable, fair, and accepted?
Yeah. So I'm going to start answering that question with something a little more broad-based,
Okay.
which is a statement I love. I heard from Tony Marzoni, who was a surgeon, a leader at the Palo Alto Medical Foundation. He said, every medical group, every healthcare system has a culture committee. And we'd all kind of get quizzical looking. He said, they just call it the compensation committee.
Yeah.
Because how you set compensation actually demonstrates your values and what you value.
Right.
And so thinking about that more broadly in those ways, is this a value to the organization to have someone give their time, which
Right.
is specific time, to that service? Yes, absolutely. Should it become so purely transactional that it's based on an hourly rate for the number of minutes that you spend sitting in that meeting? I hope not, because it has to be more than simply something purely transactional, but it has to be considered within the context of what the organization truly values. And if they don't truly value physician time in these ways, then there's something really missing. So
Right.
it's finding that balance that's key.
Well, I think that's a great way to close, and so I want to again thank you, Paul, for your time, your expertise. The slide that's up there has your contact information. We want to thank all the participants for joining us today, and we hope to see you later this month on our next webinar. So have a wonderful day. Thank you.
And thank you, boy. I sure appreciate this opportunity. Thank you.
You bet.